Let's start with something quite stark. In England, well, it's a 19-year gap in healthy life expectancy between the most and least affluent areas. Just think about that for a moment, nearly 2 decades. And this isn't just about living longer, is it? It's really about living well, those years free from serious illness. This statistic, it really throws into relief the core of today's deep dive. These intertwined problems of more people living with multiple long-term conditions, multimorbidity, and the health inequalities that just seem to make it all worse, especially for the most vulnerable patients we see. It's a critical area for anyone in health and care, wouldn't you say? Where the real challenges lie. Welcome to the deep dive. We're going to unpack what's arguably one of the most complex challenges facing healthcare right now. Our aim today is to explore how things like discrimination and disadvantage don't just impact health generally, but specifically increase the chances of people getting multiple conditions, and often much younger than you'd expect. We'll look into what's driving the variations between different groups, and crucially, how our services can actually start to help properly. This isn't just theoretical. It's about understanding the reality for patients, maybe someone like Sarah, who we might all recognize navigating this complex web, feeling overwhelmed, unheard by a system not really built for her needs.
Absolutely. And to really get to grips with this landscape, we should probably define what we mean by multiple long-term conditions, or MLTCs as we often call them. At its simplest, it's living with two or more chronic conditions.
Yeah.
And importantly, we give each condition equal weight. Now, that's quite different from comorbidity, where you typically have one main condition and others are seen as sort of secondary. But for a deeper understanding, especially of the burden on someone's life, the sheer complexity, research often looks at three or more conditions. That threshold really captures the jump in challenges patients face day to day.
And the scale of this issue, it's just huge, isn't it? You mentioned MLTCs are common
They are incredibly
and
common.
getting more so.
Yes, the prevalence has risen quite dramatically over the last couple decades. So living with numerous, often complex health problems is increasingly becoming the norm, particularly for older people. But, and this is the really crucial point, it's also increasingly the norm for those from disadvantaged communities.
Which really highlights that growing gap, that disparity we need to focus on. It's more than just clinical, it feels societal.
Precisely. It's a major societal challenge. And just to paint a clearer picture of the conditions we're talking about, we can group them into a few broad categories. First, you have the non-communicable diseases, NCDs. These are probably the ones most people think of first. Things like cardiovascular diseases, heart failure, hypertension, diabetes, various cancers, chronic respiratory diseases like asthma, COPD. They usually come from a mix of things: genetics, physiology, environment, lifestyle factors, often progressive, needing long-term management. Then second, we have communicable diseases. Now, although they start as infections, conditions like HIV or hepatitis C often turn into long-lasting chronic health problems. They need continuous lifelong management. And what makes it really complex is when these exist alongside NCDs. You get this intricate web of health needs that demands a really integrated approach. Third, and this is absolutely critical, mental health disorders are a really significant part of MLTCs. We're talking about common conditions like depression and anxiety, but also more severe illnesses like schizophrenia, bipolar disorder, and the interplay here is vital. Chronic physical illness can often trigger or worsen mental health issues.
And vice versa.
Exactly. Mental health conditions can make managing physical problems much, much harder. It's a vicious cycle. We call it psychiatric morbidity. It's not just a side effect, it's a major compounding factor. Think about your Sarah. Again, maybe severe chronic pain feeding into depression, making it almost impossible to engage with physio, for example.
Right. You can see how that spiral happens.
And finally, the fourth group is progressive physical structural impairments. Conditions like rheumatoid arthritis, multiple sclerosis, severe osteoarthritis. These cause gradual physical decline, they really impact functional ability, and they often require ongoing care, significant adaptations to life, and often a real reevaluation of identity for the person. Understanding these categories helps us see the sheer diversity and the compounding nature of what people are managing, often without the right kind of joined-up support.
That's a really helpful framework. So with that complexity in mind, let's dig into who's really bearing the heaviest burden here, because the data, it tells a pretty sobering story, doesn't it? Health disparities aren't just about if you get ill, but when and how badly. It feels like a profound injustice. What aspects of this disparity do you think we as healthcare professionals perhaps still underestimate?
I think it's often the timing and the cumulative impact. The effect of socioeconomic deprivation is probably the starkest. Research shows pretty unequivocally that people on the lowest incomes can be 4 times more likely to have multiple conditions compared to those on the highest. But it's not just the likelihood, it's the timing, the early onset. People in the most deprived areas tend to get MLTCs. That's
Mhm.
two or more conditions a staggering 10 to 15 years earlier than people in the wealthiest areas.
10 to 15 years earlier.
Yes. And for complex multimorbidity, 3 or more conditions, the onset can be 7 years younger. And what's really alarming and often missed is that this inequality, this gap, it's actually got wider over time. It hasn't narrowed.
So things are getting worse, not better in that respect.
That's what the trend suggests, yes. It's a critical worsening situation.
And what does that mean for something like disability-free life expectancy? That's about quality of life, isn't it? Not just length of life. This early onset must have a devastating impact there.
Exactly. It's all about the lived quality of life. Let me give you a concrete example. The most affluent women without multiple conditions can expect nearly 8 more years of disability-free life compared to the least affluent women living with multiple conditions.
8 years.
Yeah.
That's huge.
It's an enormous difference in actual lived quality of life. One group facing limitations, burdens, for almost a decade longer than the other. It's not just about living longer. It's about being able to work, socialize, care for family, just participate fully without illness constantly limiting you. It really paints a picture of the inequality. Now, let's also consider ethnicity. This is often tangled up with the socioeconomic status, of course, but it has its own distinct influences. Studies consistently show that people from Indian, Pakistani, Bangladeshi, Black African, Black Caribbean backgrounds, and those identifying as Black, other Asian or mixed groups are at a significantly higher risk of having MLTCs. And that's even after you adjust for things like age and sex.
So it's not just about deprivation.
No, there's something more going on. Specifically, people from Pakistani and Bangladeshi communities are more than twice as likely to have multiple conditions compared to, say, Chinese groups. And they experience much higher rates of things like diabetes, chronic pain, cardiovascular disease. This isn't just a small variation, it's a major difference pointing towards systemic factors. Perhaps things like chronic stress from experiences of racism or barriers in accessing culturally appropriate care.
And does this higher prevalence translate into mortality risk as well? That would be compounding the injustice.
It absolutely does, unfortunately. The risk of dying associated with having multiple conditions is significantly higher for Pakistani, Black African, Black Caribbean, and other Black ethnic groups compared with white ethnic groups.
Yeah.
So yes, it compounds the issue. It's not just about how long or how well you live, but the ultimate outcome too. It's a stark reminder these inequalities are genuinely life-limiting. Then there's severe mental illness, or SMI. This plays a really critical and often overlooked role. We know people with SMI are consistently more likely to have multiple physical health conditions than the general population. What's particularly alarming is when you look at younger people. Those aged 15 to 34 with SMI are 5 times more likely to have 3 or more physical health conditions.
5 times at that age.
Yes, that early onset of complex physical illness combined with SMI is a grave concern. It sets them on a really difficult path from a very young age.
And I imagine that combination has a profound impact on their overall life expectancy.
Tragically, yes. On average, people with SMI live 15 to 20 years less than the general population.
15 to 20 years.
And the crucial thing to understand is that this is primarily due to preventable physical illnesses.
Preventable.
Yes, which points directly to a systemic failure in providing integrated care and proactive physical health management for this incredibly vulnerable group. We are, quite simply, failing them on basic physical health needs. And finally, there's emerging evidence around sexual orientation. It's still developing, but becoming more robust. Recent analysis, carefully adjusting for factors like deprivation, ethnicity, age, region, suggests adults from sexual minority groups are more likely to have long-term mental and physical conditions. What seems particularly concerning is that young sexual minority adults, especially women, appear much more vulnerable to living with multimorbidity.
That's another layer of complexity then?
It is. It's an area needing more research, definitely. But the initial findings highlight another significant disparity we need to address with more inclusive and sensitive healthcare.
Right. This is where it gets, well, really fascinating and quite sobering, actually. The research delves into the everyday reality of living with these conditions. And it's often described not just as a burden, which is how we might think of it, but as a complex, multifaceted workload. It permeates every aspect of life. This completely reframes how we should think about patient adherence, doesn't it? It's not just compliance, it's a huge, often invisible job. Let's hear about what that work actually involves.
Indeed. Qualitative research gives us profound insight here, identifying 8 key themes of this work. And it's crucial to see how they overlap and link together, creating this compounding effect. The first theme is accumulation and complexity. This is about the sheer extra effort involved when managing multiple conditions, not just one. Common difficulties, well, constantly getting new conditions, the frustration of not getting clear diagnoses for new symptoms, the complex, unpredictable interactions between diseases or treatments. Patients face this constant, mentally draining need to make decisions, prioritize which symptom to tackle, often amidst profound uncertainty. As one person put it so well, the complexity, its intensity and impact on daily life can vary from time to time, from day to day, but also during the day. It's relentless.
That really highlights how patients are forced to become their own experts, their own advocates, doesn't it? Which shouldn't be the case. And this relentless demand, it leads to daily exhaustion, overwhelm, sometimes just disengaging from it all because it's too much. We've kind of forced this role upon them.
It's exactly that. The second theme is learning and adapting. This is the continuous mental and emotional labor needed. Learning about new conditions, existing ones, understanding the management, making all the necessary life and lifestyle changes. Patients are constantly seeking information, reevaluating things, comparing themselves to others, trying to make sense of symptoms. And you often get conflicting goals between patients and us, the professionals, adding to that cognitive load. This theme also covers what's called biographical work. That's the deep disruption to identity, to sense of self, often a real grief reaction for the life they've lost.
Yes. The social impact.
Significant social losses, isolation, restricted activities, feeling prematurely old, losing independence, losing cherished roles. Remember Sarah the baker? A quote captures this poignantly. "I would like to bake bread. I always did that. What fun it was. I can't stand up for that long because of my back, so no point in thinking about it."
Oh, that really hits home, doesn't it? It's not just managing symptoms, it's this profound emotional social shift. Redefining who you are. It requires huge adjustment and often involves a quiet grief.
Precisely. Then the third theme, investigation and monitoring. This is that relentless cycle of tests, checks, both self-monitoring blood sugars, blood pressure, insulin doses, multiple times a day, and the health service monitoring regular appointments, endless diagnostic tests, keeping track of specialized meds. A huge difficulty, often invisible to us, is the lack of coordination between providers. Trying to schedule appointments, tests from different clinics, often miles apart. It's a nightmare for patients.
The logistical juggling act.
Absolutely. And participation in preventive care, like cancer screening. It becomes incredibly hard because of poor health, mobility issues, just lack of time and energy. So often people just don't engage, which creates further risks down the line. One patient put it perfectly. Let's go through all that. Who has the time and energy? It's hard enough when you're healthy. When you're not feeling well at all, it's difficult. I don't have the energy. I don't have the time. I don't want to deal with it. Fourth theme, medication work. Polypharmacy, essentially. The sheer workload of managing numerous medications every single day. It leads to complex, confusing regimens, potentially high costs, and a huge time commitment. Ordering, collecting, actually taking the pills, often at very specific times.
You can just imagine the mental load. One patient described it vividly. It's a struggle. It is a huge struggle. Every week I have to put my beds in pill boxes if I don't, with as many different medicines. To be perfectly honest, I couldn't even tell you how many pill bottles it really is. Look, it's this daily, invisible battle just to keep up with treatment.
It truly is. And this theme also covers coping with side effects, drug interactions, which can seriously impact ability to socialize, make plans, travel. And medication adherence, it's not just about forgetting, is it? It's complex regimens, fear of side effects, perceived harm, stigma, dietary changes needed, even practical things like medication shortages. It's a minefield. Fifth is health service and administration. This focuses on the workload related specifically to health services, most notably the sheer number of appointments, often different doctors, different departments, different hospitals or clinics.
The fragmentation issue again.
Yes, the devastating impact of fragmented care. Services focusing on single diseases, not the whole person. This leads to a huge amount of that invisible work for patients. Managing their own health info, carrying notes between providers, keeping medication lists accurate, sometimes even correcting errors in their own records that we, the providers, don't see. One person said, "Nobody wants to help you." And this administrative burden, it's like a systemically regressive tax on illness.
A tax on illness. Explain that a bit more.
It means the sicker you are, the more complex your needs, the higher the cost in time, effort, stress, just to navigate the very system meant to support you. It disproportionately hits those who can least afford it.
And beyond the fragmented care itself, there are those practical hurdles, travel, transport, the time, the costs, the planning, amplified for people in rural areas or with mobility problems. Plus, access issues, waiting times, sometimes leading people to just not attend because the effort outweighs the perceived benefit.
Absolutely. Sixth theme, symptom work. This covers the wide, often debilitating range of symptoms. Key ones that come up repeatedly are chronic pain, significant physical limitations, mobility problems, and that pervasive fatigue, exhaustion, lack of energy. But researchers identified over 100 individual symptoms mentioned across studies.
100, wow.
Yes, things like sleep problems, low mood, vision, hearing issues, breathing problems, balance issues leading to falls, weight changes, decreased strength, chronic cough, cognitive difficulties, nausea, the list goes on.
And it's fascinating and really quite sad that people often don't even seek help for some symptoms, like chronic back pain, just believing there's nothing that she can do. It suggests a real resignation, a lack of hope that the system can actually help with some of these core burdens.
It speaks to a deep disillusionment, doesn't it? Seventh theme, emotional work. This is huge. It highlights the significant emotional toll of living with MLTCs, both the direct impact on the individual and also their awareness of how it affects others. Common emotions described: worry, frustration, guilt, loneliness, isolation, sadness, feeling overwhelmed, anger, despair, embarrassment, shame, disgust may be due to not being able to work, or changes in appearance, fear, stress, feeling powerless. A powerful quote captures this. What bothers me the most is that I don't want to be a burden. I don't want to be a hassle. No one should have to take my needs into consideration. That is hard to accept.
That often leads to psychological instability, a profound sense of loss, a reevaluation of self. Yet it's quite remarkable, isn't it, that some people do manage to find positive emotions like hope, acceptance, incredible resilience in the face of it all.
Absolutely, that resilience is remarkable.
Yeah.
The final theme, eighth, is financial work. This details a substantial hit to personal finances. MLTCs often mean reduced ability to work, cutting income, limiting opportunities, plus the direct costs, medications, consultations, self-management tools, maybe specific diets, gym memberships if advised travel, parking. It all adds up to a significant financial burden.
And for many, this means significantly increased healthcare costs, creating impossible choices, balancing healthcare against basic bills, family needs, any kind of leisure. It impacts savings, debt, housing security. One person put it starkly: all my money goes on my health aside from basic bills. I do not buy treats, clothes, haircuts, toiletries, things for the house. It's just unsustainable for so many, especially those already struggling financially.
And that powerfully underlines how socioeconomic deprivation shapes this whole experience. Some rely on family or inadequate benefits. A negative social environment, lack of support, chronic stress directly impacts the ability to cope financially and emotionally. It just makes the overall workload heavier.
So let's try and pull this together. What's really driving these alarming disparities and this massive workload for patients? It's clearly not just down to individual choices, is it? There seem to be deeper systemic things at play that we, as medical professionals, really need to get our heads around.
Indeed. We clearly see socioeconomic disadvantage as a root cause. There's that strong, consistent link between socioeconomic inequality and MLTCs, tied to factors like lower educational attainment, living in deprived areas, unhealthy lifestyles, often driven by circumstance, not choice, food insecurity. These aren't separate issues. They're tangled together, creating this cumulative disadvantage over a lifetime.
But it's important to stress the nuance here, isn't it? While the links are clear, the exact causal pathways, how poverty actually translates into these multiple illnesses, are still complex and not fully mapped out, which points to a critical area for more research, doesn't it, to understand the how.
Precisely. We have hypotheses, of course, mechanisms like health behaviors, diet, smoking, alcohol, access to material resources, money, housing, and the psychological toll of inequality, chronic stress, which we know affects the body. But robust evidence confirming these specific pathways definitively is still, well, a bit scarce. We need more research to pinpoint exactly where interventions would be most effective. What we do know is that many factors intersect and reinforce each other. It's like a cruel feedback loop. For instance, racism, other forms of discrimination can combine with things like age, gender, sexual orientation to create disadvantage in accessing resources, economic, physical, social. This then fuels socioeconomic and health inequalities, which can accelerate MLTCs in certain groups. It's disadvantage breeding more illness.
And we see that with depression and MLTCs too, creating that vicious cycle, driving each other through things like low socioeconomic status, psychosocial stress, a constant downward spiral for many.
That's right. And we also see how environment and occupation play a big, often unacknowledged role. Remember the retired cleaner working long hours, relying on Coke and cake for energy because she's exhausted? That's not a choice in the usual sense.
Or the community manager in Middlesbrough saying, it's hard to educate a 30-year-old about healthy eating when they've been eating microwavable food their whole life. These are deeply ingrained habits shaped by circumstance, lack of time, money, access to fresh food. They're incredibly hard to shift with just advice.
Okay, let's shift focus slightly to the healthcare system itself. How does it respond or perhaps fail to respond to these really complex intersecting needs? Because for us, the medical audience, this is where we need to see how our current practices might even be part of the problem.
Well, all too often, the system fails to see the whole person. It maintains that narrow, siloed focus on individual diseases, which frequently means mental health needs, emotional well-being just get ignored, which inevitably makes everything worse for the patient. Think about Sarah, again, diabetes clinic here, pain clinic there, mental health service somewhere else, different doctors, no communication. It leaves her feeling completely fractured.
And that disjointed approach, it creates so much of that invisible work for patients we talked about. They end up coordinating their own care, ferrying information, keeping medication lists, even correcting errors in records that we don't see. It's an unacceptable burden.
It truly is. Remember that quote, "Nobody wants to help you." This invisible work acts like that systemically regressive tax on illness. It hits the most complex patients hardest. It's not just inefficient, it actively pushes patients away, turns them into reluctant, unpaid care coordinators. There's also this pervasive lack of trust and personalized care. Research highlights widespread distrust, especially among some ethnic minority groups, in primary care, in mental health services, fear of discrimination. This sadly deters people from seeking help or from being fully open when they do.
And we heard those anecdotes that really bring this to life. My mom takes a while to explain. I think this is why the GP doesn't listen. Or the patient saying, I only recently learned that it's not good for me. I wish someone had properly explained it in normal English. It reveals this profound communication gap, doesn't it? Impacting understanding, adherence, outcomes.
It absolutely does. And this links to poorer disease management and less continuity. Evidence shows, for example, Black people with MLTCs were less likely to get statins, less likely to hit blood pressure targets. And a large analysis of GP records showed people from Bangladeshi, Pakistani, Black African, Black Caribbean, other Black backgrounds had less continuity of care than white patients. Deprived areas also meant less continuity, with ethnic minorities in the most deprived areas getting the least.
And continuity matters, doesn't it? That ongoing relationship.
Critically important. It's linked to lower mortality, fewer hospital admissions, fewer complications, higher patient satisfaction. Especially for complex patients, it's a cornerstone of good care, yet it's disproportionately denied to those who need it most.
Okay, so given all this complexity, this workload, these systemic failings, what does truly effective support actually look like? How can we, as a medical community, move towards a system that not only manages the conditions, but actively tackles these deep-seated inequalities? The research does offer some compelling insights, doesn't it? This is where we can hopefully make a real difference.
Yes, there are several key strategies. One is promoting healthy lifestyles. But, and this is a crucial but with real nuance, research clearly shows healthy lifestyles can extend life expectancy even with MLTCs by up to 7 years. Not smoking and regular exercise give the biggest benefits. However, we absolutely must acknowledge it's significantly harder to adopt these lifestyles in deprived circumstances or if you have a mental illness.
Right, so just telling people isn't enough.
Exactly. It pushes back against that simplistic idea. It demands more tailored, community-level interventions. Things like smoking cessation programs, specifically designed for people with severe mental illness, acknowledging their unique challenges rather than a generic approach that just won't work for them. Another vital element is bespoke support for self-management. People facing both deprivation and multiple conditions need extra, targeted help to manage effectively. And we, as health professionals, can make a huge difference with seemingly small adjustments that actually shift the burden. Things like providing really simple, clear explanations and diagnoses, actions needed, actively checking the patient understands what's been said, and critically, asking patients for their opinions on what they want to happen next.
Making it truly collaborative.
Precisely. So the patient, like Sarah, feels seen, heard, and their personal workload is acknowledged and hopefully eased a bit. Then there's the urgent need for integrated models of care, and that includes medicines management. We desperately need systems, especially in busy primary care, that support managing multiple conditions together, not just single diseases in isolation.
So breaking down those silos.
Yes. Shared records, perhaps cross-specialty team meetings or huddles, maybe even funding models that reward whole-person care over ticking single disease boxes. And it absolutely includes helping clinicians reduce the number of medications prescribed, deprescribing. That can massively reduce patient workload and risk.
And that polypharmacy challenge, managing multiple medications, comes up again and again as a major burden. So what makes deprescribing successful? It sounds tricky.
It is tricky, and success hinges on several things. First, clinicians need clarity. When is it okay to prescribe outside guidelines? What are their responsibilities? They need to feel supported. Second, they need good data, full medication history, life stage, key events like a recent bereavement, which can massively impact medication needs and coping capacity. Third, and often missed, discuss stopping a medicine right when it's first prescribed. Build that shared understanding of why it's being used and when it might stop. And finally, absolutely foundational is a strong, trusting relationship with the patient.
Without trust, it's hard to change long-term meds.
Exactly. Imagine explaining to Sarah why reducing a pill she's taken for years might be good. That requires trust, built over time. We also must stress the vital management of combined physical and mental health needs. People with this combination are among the most vulnerable, largely because of that significantly reduced life expectancy we talked about. There's a huge pressing opportunity here to improve care, given so many of their physical illnesses are preventable with genuinely integrated services. And beyond the clinic, addressing the wider determinants of health is paramount. We need high-level population strategies for maximum impact. Upstream solutions, things that delay conditions starting and reduce MLTCs in deprived communities before they take hold.
Like what sort of things?
Creating safe, unpolluted outdoor spaces for activity. Promoting better paid jobs with safe conditions. Ensuring access to good quality neighborhood services. Decent housing, reliable public transport, good schools. These basics profoundly shape health, and we, as health professionals, have a role in advocating for them. Think about social prescribing, linking people to community support, or housing first, approaches recognizing stable housing as a health intervention. The role of technology also offers potential. Virtual appointments, better digital coordination between specialties, patient-held electronic records, these could help. However, there's a real danger they could also increase treatment burden and widen inequalities for those who can't easily access or use tech.
The digital divide.
Precisely. People facing socioeconomic disadvantage, homelessness, language barriers, cognitive impairments. Tech needs inclusive design and proper support to avoid making things worse for some. And finally, evidence suggests multidisciplinary teams and care coordinators can improve outcomes. Qualified care coordinators seem critical for joining up communication across sectors, improving teamwork, helping bridge those fragments. But while these teams show promise for patient satisfaction, consistent evidence for improving clinical outcomes or reducing healthcare use in non-hospital settings is still, well, developing.
So a good step, but not a magic bullet yet.
Exactly. Promising, needs careful implementation and evaluation to ensure real impact.
Well, this deep dive has really brought into sharp focus how disadvantage just gets magnified for people living with multiple conditions. The way these issues intersect has this cumulative and frankly devastating impact on disability-free life and overall life expectancy. It's not just about managing diseases, is it? It's managing this whole personal ecosystem of challenge.
And just to reiterate, while we know lifestyles and other factors drive both inequalities and MLTCs, those precise causal pathways, they're still not entirely clear, which means we need more longitudinal research to really pinpoint the most effective interventions, to understand the how and why, not just the what. What the evidence consistently tells us is our current system is built for single conditions, not multiple ones, and it too often neglects the needs of those facing the greatest health inequalities. That emphasis on self-management, while well-meaning, can ironically just pile more onto the patient's workload if it's not carefully coordinated and genuinely tailored, turning Sarah into that unpaid, overworked care manager.
So the call to action feels really clear. We need a fundamental system-level shift, developing holistic clinical guidelines for MLTCs, policies to ease the financial burden, properly acknowledging the huge emotional and biographical impact, and really pursuing this idea of minimally disruptive medicine care that works but fits into life rather than taking it over.
Absolutely. And greater investment in research is vital.
Yes.
Focus not just on diseases, but understanding those causal pathways, identifying burdensome aspects of care within our data, and critically ensuring meaningful patient and public involvement. We need to hear more voices like Sarah's actually guiding our research questions and priorities.
So reflecting on all this, what really stands out to you from this deep dive? It is a complex picture, definitely, but it feels like one where, collective ambition, properly integrated care, and genuinely tailored compassionate approaches can make a real difference, transforming lives, reducing these unacceptable inequalities. It's not an unsolvable problem, is it? It's more a call to reimagine how we deliver care. If you found this deep dive insightful, please do take a moment to rate and share it with colleagues who might also find it valuable. We really believe these conversations are vital for moving healthcare forward for everyone.